Welcome to this session of Maritime Medicine, in which we discuss behavioral emergencies. By the end of this session, you will be able to list 5 signs and symptoms each of the following psychological disorders, list the steps of managing an acutely psychotic violent patient, and list at least 5 interventions that can be performed to minimize the risk of a behavioral emergency. To understand what behavioral emergencies are, first we have to understand behavior. And behavior, simply put, is the way in which people act or perform, and it includes physical and mental activities. So a behavioral emergency is a situation where those activities, actions, and performance are simply unacceptable or disturbing or intolerable for the situation by either the patient or the patient's community. So when is bad behavior simply unacceptable? Well, if it interferes with your core life functions, that's a problem. If it poses a threat to your life or the well-being or to the lives or well-being of others, that's a problem. And if it's far off from the societal or community normal, that's also a problem. And that last one can be a bit fuzzy because different communities have different standards. So we'll start by talking about anxiety, which is something that all of us experience to one degree or another, but can be debilitating for certain individuals. And anxiety is excessive concern over something that shouldn't cause that much concern. And that stimulus can be physical or social, or it can be mental or psychiatric. The symptoms are obviously excessive concern or worry, so anxiety, inability to make decisions because of that, phobias or irrational fears, fears that are in excess to the threat, and there may be some degree of dependency. That is, they look to others to do things or help them in many different ways because they can't figure out how to do things themselves. Now, a panic attack can be an extreme manifestation of anxiety, or it can be a problem in and of itself. And unfortunately, panic attacks can look very much like medical issues. So the psychiatric definition is there are 4 of the following symptoms that peaking within 10 minutes of the event. And again, this is somewhat problematic because you have to differentiate it from a medical cause. So heart racing, sweating, shortness of breath, and chest discomfort can all be symptoms of an irregular heartbeat or a heart attack. Same with nausea and abdominal distress. So as you look at these, you realize that it can be very difficult to differentiate the panic attack from the medical emergency. Mania is another psychiatric disturbance, behavioral emergency that you may have to deal with, and this can be part of bipolar disorder, which is depression and mania. It can be mania on its own, or it can be situational or toxic drug-induced mania. So in a manic episode, people feel grandiose, they feel much more self-esteem than probably the situation warrants. They don't need to sleep. They talk quite a bit. They have flight of ideas. Their thoughts are racing. They try to achieve things, and unfortunately those things are often things that are not safe for them, so they can become hypersexual or spend a lot of money or do things that because they feel that they're above the law, and all those things are problematic, obviously. But they have a feeling of being very, very powerful, and really a feeling of being in control of what's going on, even when clearly they aren't. Now, a little bit of low-grade or hypomania is probably a good thing for getting work done, and as an emergency physician, certainly I thrive on some hypomania every time I work. If I didn't, I wouldn't be able to move patients through the department. I wouldn't be able to jump from one sick person to another. The major issues in a true manic episode, though, are the complete loss of judgment. So because these people feel so powerful, they feel invulnerable and really show very bad judgment and take risks. And there's a potential for psychosis as well, which is basically a deranged interpretation of stimuli from the environment, hearing things that aren't there, seeing things that aren't there, having delusions. And it may be part of bipolar disorder, as mentioned previously. Now, unfortunately, you may have to deal quite a bit with depression and suicidal ideation amongst crew members. The nature of your work, the isolation, separation from family, all of these things put you at increased risk of having a depressive episode or feeling suicidal. In addition, substance abuse and other drugs of abuse may also contribute. In a major depressive episode, there's deep feelings of being worthless or feeling very guilty with a depressed mood that's there continuously and essentially no interest in things that used to make you happy, your daily activities. Oftentimes there's recurrent thoughts of death, weight changes, either weight gain from no activity at all or weight loss from not eating. Sometimes these individuals will sleep quite a bit. Sometimes they can't seem to sleep at all. They may be very agitated. Psychomotor agitation is excessive movement, or they may seem very slow, as if they can't do anything at all, and they have a good deal of difficulty thinking and making decisions. Now, one of your biggest risks in depression is suicide, and for the truly depressed, it seems to be a factor in 50% of suicides. This may also be part of bipolar disorder, the opposite spectrum from the mania, and there are rapid cycling patients who very quickly transition from mania to depression, and you may see that can be problematic. Now, if something bad happens, either shipboard or to crew members' family back home, or someone dies on shipboard, you can expect to have situational depression, where it's an appropriate response, sadness, guilt, sometimes feeling poorly. That's much less likely to lead to suicide, although it can be the trigger for someone who's already depressed. So differentiating major depression from situational depression is important. Anyone taking this class has probably had some experience with sleep disorder. It's definitely the schedule that we're on as professionals who work round the clock certainly impacts our sleep cycles. So a sleep disorder is an inability to fall asleep, stay asleep, or have decent sleep, and not due to a specific medical illness. So, for example, somebody with obstructive sleep apnea who stops breathing when they sleep, and then they almost wake up, and so they get a very poor night's sleep because of that. That's not what we're talking about. We're talking about people who have non-medical causes of their difficulty sleeping, and certainly, again, in your environment, the shift work, switching between days and nights, not getting necessarily a good pattern of sleep, and having your circadian rhythm disrupted is a major factor. Time zone changes will also significantly impact sleep. You're in high-stress situations, often with an inability to really decompress after the event in a way that lets you then get fully rested. And we all use stimulants, caffeine or others, to help compensate for our difficulty sleeping, and that in turn contributes to worsening sleep disorders. Now, unfortunately, you're also going to have to deal with issues of substance abuse. And while using psychoactive substances like alcohol in and of itself isn't necessarily a behavioral problem, inappropriate or excessive use is. And how do we define inappropriate? Well, if they impact your daily functioning, so you can't do things without using the substances, or they're damaging your health, and you know they're damaging your health, but you continue to use, or they impair your judgment, which is a real problem if you're using in the workplace, or you have decreasing periods of sobriety. So maybe you used to become intoxicated once a week, and now you're down to once a day, and you're only sober 18 hours a day, as before you were sober 6 days a week. That's a real problem. And if you're increasing your efforts to obtain the substance, that's also a problem. And those issues are what define the abuse part of substance abuse. Okay, now let's talk about folks who are really disturbed, and we're going to talk about schizophrenia, which is a disorder of the perception of an interaction with reality. So people perceive reality as different than everyone else and interact with it in very odd ways. So the symptoms include delusions, which are beliefs about things that aren't true, hallucinations, which are seeing or hearing things, usually hearing things in schizophrenia that other people don't, very disorganized speech, and bizarre behaviors. They can be catatonic and non-interactive at all. These are debilitating issues, and they socially withdraw and lack emotional expressiveness, so it's very disturbing for a lot of people to interact with these individuals. So the problem is that someone who's psychotic, who's delusional, hallucinating, acting bizarrely, may actually have a medical emergency, and this is called delirium if there's a medical cause for it. Urinary tract infections, drug overdoses, problems with the salts in the blood, problems with the thyroid can all induce this. So you need to rule out medical disease as the cause, and that can be extraordinarily difficult. So it's very helpful if the individual already has a diagnosis of either schizophrenia or some other form of psychosis, because that increases the chance that that's what's going on, although it's not 100%. Really the only test that you'll have, two tests that you'd have to be able to sort this out, would be a fingerstick blood glucose, because very low or very high blood sugar can make people act psychotic, and a urine dipstick to make sure there's not a urinary tract infection. So you may end up needing to manage a violently agitated individual, so someone who is extremely agitated and is dangerously violent. And there may be a medical cause, it may be a psychological cause. You won't necessarily know, but your first issue is protecting yourself and the crew and then controlling the patient. Now this may require physical restraint, it may require medications and sedation. You need to talk to medical control about that, and you need adequate personnel to control patients. When we were seeing patients on bath salts at our peak in 2011, it would often take 8 to 10 people to physically control the violent behavior of one individual who was intoxicated on bath salts. So it's coordinated restraint. You manually restrain them, and then they need a device, and you give them sedative medications. And the ones that you would have available would be narcotics and benzodiazepines. But again, talk to medical control about that. So once you've got them physically controlled, you need to look for medical cause. So hypoglycemia, check a blood sugar. They could be intoxicated. You may just figure that out clinically. Look for signs of a head injury. Get some history from the bystanders. Was there a seizure, and is this just what's called a postictal state? Is it a low oxygen level, which is very bad, or any of a number of things which could do this? And you need to try to sort that out. Now, of course, it's best if you can just avoid any of these psychiatric emergencies and behavioral emergencies. So recognize fatigue states amongst your fellow crew members. Make sure adequate nutrition is occurring, and make sure that there's a policy and it's carried through to limit access to psychoactive substances. You need the community to be flexible, to support people, and be alert for individuals who are starting to isolate themselves, because that could be a sign of depression or early psychosis. Make sure that individuals are able to actually perform their assigned tasks, and more than anything, maintain a good sense of humor. Please complete the knowledge review for this session to document attendance, and if you have any questions, please contact your instructor or professor. Thanks.